Trying to.
We are good.
Okay, thank you, Cody. I apologize.
Yeah.
All right. Good afternoon, everyone, and welcome to this meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. The commission's strategic plan for 2020 through 2023 is committed to advancing the commission's vision of well-being for all Californians. Cody, can you please bring up the strategic goal slide? Thank you, Cody. Now we will take roll and establish a quorum. Jeff, can you please take roll?
Can you hear me now?
We can, Jeff. Go ahead,
Sorry
please.
about that. Commissioner Bontrager. Commissioner Brown.
Here.
Commissioner Bunch. Commissioner Carrillo. Commissioner Carnavale. Commissioner Chambers. Commissioner Chen.
Present.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Here.
Commissioner Mitchell.
Present.
Commissioner Robinson.
Present.
Commissioner Rolette.
Here.
Commissioner Tamplin.
Here.
Vice Chair Alvarez.
Here.
Chair Madrigal Weiss.
Here.
Madam Chair, you have a quorum.
Can I just say that I'm here? I'm sorry, it wouldn't let me, it said the host wouldn't let me unmute. This is Commissioner Bunch.
Now you have even more of a quorum.
So, Commissioner Bontrager, same scenario. I'm here. Oh, couldn't unmute.
Commissioner Chambers is here as well.
You definitely have a quorum, Madam Chair.
Thank you, Jeff. So normally we would include in our meetings an opportunity for announcements. Given that we just recently met, we will skip announcements today to move on to our primary item of business. We will meet later this month on September 28th in Los Angeles, as well as online. At that meeting, we will once again share announcements. With that, it is time to move on to agenda item 2, general public comment. This time is reserved for comments on items that are not on the agenda. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact us at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it is your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you're unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, staff will let you know, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone maintain time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given to you during your public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate your closed captioning feature located in the control bar at the top or bottom of your screen. Okay, and going to public comment.
One quick comment, just Chair Madrigal wise, I just wanted to announce my presence. I couldn't unmute at the time of the attendance was taken. This is Itai Danovich. Thanks.
Thank you, Commissioner Danovich. So, Mariani, then, would you please open the line for general public comment?
Yes, we have 1, 2, 3, 4, 4 public comments. I'm sorry, 5 of them. They're still popping up slowly. We have about 5 comments. The first we have is from Stacy. Your line is open.
Thank you. Good morning or good afternoon, Commissioner. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. First, I want to sincerely thank you for calling this meeting for another opportunity for people to comment on the governor's proposal, which that we are very glad has been being amended. So thank you so much to the commission for giving this opportunity. I just hope that both the CFLC and the CLCC, the Client and Family Leadership Committee and the Cultural and Linguistic Competence Committee will be meeting soon, because I believe that even in your rules of operation, they are still to be convened, and I wish that they had been convened to review this more, but I know it's just been so busy. So in some ways I understand. I hope they will be convening before the end of the year, because they've only met once. But thank you again for this meeting, and I commend all the commissioners that are here. Thank you so much.
Thank you, Stacy.
Thank you. Next we have Richard. Your line is open.
Good afternoon, commissioners. I just have a concern when I sent an email to the Oversight Commission, whether it's being sent to the commissioners or part of the packet for that particular month, when you do have a commissioners meeting, so that they're aware about my concerns, issues, and feedback, and etc. That's my only comment in regards to sending the email, since I do not get any acknowledgements or follow-up or anything, so I don't know whether it's actually being captured and followed through. Thank you.
Thank you, Richard. We will follow up with that.
And next we have Emily. Your line is open. Emily, if you want to go ahead.
Sorry, I pressed the wrong button earlier. My name is Emily Lutrong. I am a former MHSOIC Client and Family Leadership Committee member. Also a recent national speaker for NAMI, Nationals Faith Net Pathways to Hope Conference. It was showed outside of California, 14 states across the country just 2 weekends ago. And, you know, I'm very concerned about the mental health care system, because in the last 10 years I've been involved, and I know that I had a compassion fatigue and burnout for the last 1.5 years or more, because I basically distrust the system. I want to trust in the system, but I don't trust in the system. And I am even more traumatized because I was 5150 by accident just 1 month ago. And I wish this experience on no one, because I am so traumatized to the point that I cannot go inside a hospital by myself, because I am in fear for my life. I feel so violated. like as if it's worse than rape. Trigger warning, sorry. But this is the reality of what is going on the ground floor. If we are not helping people like me, and on top of that, they didn't communicate with me, those first responders, none of them, and I'm shaking right now. I'm re-traumatized, but I know I have to share my story, because if this is happening to me, it's happening to anyone else. And officers are being asked in a split second, what do we do with this crying woman? But I know how to calm myself down and ground myself. And these other people do not know who I am, and they have never known that I've done over 150 speaking engagements to say, hey, I care about suicide prevention. Why are you 5150ing me? So I want to trust in the system, but I do not. And it's very hard, because they all the healthcare agencies now want to charge me around $11,000 to $12,000 now. So that's very scary. I was put in confinement for 50 hours and not allowed to have my phone, and not given the documentation of what is your hospital's protocol for a 5150, and the nurse would not give that to me. So anyways, I've been a mental health advocate for the 10 years, and I always say with help there is hope, but this is not help. It was harmful and traumatizing, and I'm sad, so sad that it had to happen to me, because I want no one to fall.
Sorry, Emily, we're gonna, if you could wrap up.
Yes, thank you so much for listening.
Emily, thank you for being here. Thank you for sharing that story with us. And we all have to work together, definitely, to change the system and absolutely build trust. So thank you for being here, Emily. Thank you.
All right, John, your line is open. Please go ahead.
Thank you, and just echo that. Thank you, Emily, for sharing. John Drebinger with CBHA, the California Council of Community Behavioral Health Agencies. Just wanted to note that our association has registered a neutral position on SB 326, noting concerns both to the author and to the administration. We've had some really fruitful conversations there. Really appreciative of the amendments that have been made so far. Taking a look at the ones that became available today, really appreciate the specific call out of community defined evidence practices. Hope to get even more clarity there and see more amendments come through. And just wanted to note that position, and also thank this body for all of the work that you've done to just give a platform to stories like we heard today, and to a lot of the community-based advocacy that has been working on refining this protocol for the work that you're doing.
Thank you, John.
Next is Hector. Hector?
Yes, hello, my name is Hector Ramirez. I'm a direct consumer of the Los Angeles County Department of Mental Health, which serves over 250,000 individuals in Los Angeles County. Los Angeles County is one of the major beneficiaries of the Mental Health Services Act funding. And one of the reasons that I'm here today is you're going to have conversations today about modernization and some of the concerns, particularly for equity-seeking populations. The Los Angeles County Department of Mental Health has begun its MHSA stakeholder process again, and is doing it in a way in which it's purposely, even after having requested not providing materials in Spanish for Spanish-speaking LA County residents, it's not providing disability accommodations despite having requested disability accommodations and having filed multiple complaints. As you talk about some of your oversight and accountability duties, this again is one of the issues that I bring forth, since the beginning of the MHSA. Los Angeles County, which has the largest population of Spanish-speaking individuals and one of the largest groups of people with disabilities, particularly mental health, we're not able to really equitably participate and benefit because of the lack of oversight that the department is not willing to do or the county is not able to do. And we come to you over and over for a remedy. And so this continues to be a significant issue that we see played out in our communities. As Emily mentioned, most of our peers are either in jail or unhoused out on the street because of the inequities within the system. So I really wanted to highlight that again, as I've done over the years, of how my peers and my communities are being left out of the mental health services projects that are supposed to be designed and driven by us.
Thank you, Hector.
Susan, your line is open. Please go ahead.
Good afternoon. Thanks again to the commission for hosting this forum. My name is Susan Gallagher, Executive Director of Cal Voices, and wanted to comment a little bit on how the stakeholder grants and sort of the way in which they were changed during the last round, some three or more years ago, where it moved everything rather than to have a statewide focus for advocacy for the stakeholders back into their local communities. And I think there was a lot of folly in that. And I want to make sure that it gets brought and put on the record, because I see that really connected to a lot of the bad legislation that has come before us in the last few years, including Care Court. If you don't have any client advocacy at the statewide level, if you did, that may not have been so easy to pass, but we didn't have that at the statewide level because those contracts were forced into doing it at a local level. And this is statewide advocacy. So I just really want to encourage the commission in the future years that we don't go just to local level activities, but we do statewide advocacy, because I don't see things like Care Court, SB 43, and now this modernization proposal popping down from on high without any, client involvement or stakeholder involvement at all from anybody. If all of those entities that were being funded were able to do statewide advocacy, if we were able to do that statewide advocacy, if everybody that got those grants was able to do that in these last few years, I don't really think these things would have passed. I certainly don't think they would have passed so easily. And so I just think we have to remember that. And I encourage you to go back to statewide advocacy. This government is really rolling over the community, and it's really sad to see. Sad to see something like SB 326 come and change the whole mental health system without any stakeholder input. And it's just been really shocking to all of us and very jarring to see that services are going to change, that hundreds of thousands of Californians will be deprioritized for services as a result of this shift towards housing. And so really urge the commission to take a stand opposing it, but we can talk later about that. Thank you very much.
Thank you, Susan. So there was a glitch in our system. We had Claire Cartwright. So if you still wanted to make comment, Claire, you can, but if you could raise your hand, we're going to have Nanette Barker be the final comment, and then Claire, well, not final. Claire, if you still wanted to make comment, then you will be after Nanette. So Nanette, please.
Hi, just really, really quick. Thank you so much. Thank you for having this meeting. Just Sheriff Bill Brown, you're unmuted, and I've been in that place where I've accidentally been unmuted and I've said something to a colleague or something, and it could have been something completely off topic. So I just want to give you that heads up. Thank you.
Oh, that was kind of net. Thank you. So, Claire, I don't know if you wanted to still make comment or not. I just know that there was a glitch on our end. So, if not, then Mariani, is that all we had?
Yes, Chair. This is Lester. There are no more public comments.
Okay. Thank you, Lester. All right. Thank you, everyone, for your comments. We are going to go ahead and move on to agenda item 3, the Governor's Behavioral Health Reform Proposal. Over the last few months, the commission has received several briefings on the governor's reform proposal and the language in Senate Bill 326, the implementation legislation carried by Senator Susan Eggman. The administration has been very generous with their time and has presented their proposal to the commission as it has been modified, including just 8 days ago. Today, we will hear from our legislative director, Kendra Zoller, on the status of the bill with a focus on recent amendments. Following her presentation, I am hoping for discussion among commissioners that will result in our taking a position. As Kendra will explain, the bill recently passed out of Assembly Appropriations, Appropriations Committee, and will next head to the full Assembly for a vote before it returns to the Senate for concurrence. We have held off taking a position on the legislation as the administration has shared along the way that major amendments were planned. We are now very close to the end of the legislative process, and the bill is in or near its final version. Kendra, please walk us through the status of the bill and the recent amendments.
Great, thank you for having me. I'm going to share my screen and make sure it's working correctly. Okay, can you see the PowerPoint and hear me okay?
We can both. Thank you, Kendra.
Great, thank you so much. Today I will provide an update on Governor Newsom's modernization proposal. There's been quite a few amendments, including just some in print today that I quickly tried to review with staff here to give you an overview of what is in them. It's not an analysis as we are still reviewing the amendments, but hopefully it'll give you a good idea of what the bill looks like today. Here we go. All right, just a tentative timeline here to give you an idea of where we are at in the process. As the chair just said, the bill, I'm talking mostly about SB 326, not necessarily the bond bill, but AB 531, but that also passed the fiscal committee on Friday. And both bills are heading to the floor in their respective locations. So SB 326 will be on the assembly floor. That is got the yellow highlights circle there on the graphic I have. So we are almost to the end of session. The last day to amend is September 8th. Bills have to be signed into law by October 14th. As you're aware, this will go on to, if passed and signed, it will go on to the ballot, the primary ballot on March 5th, 2024. There's a rolling implementation starting January 1, 2025. Some of the sections would go into effect 2026, 2027. And just noting here, the next election for governor is in 2026. So if this should pass, there's just a lot of changes that will be ongoing in the future. Go to the next slide. Oops, how do I go back? Uh-oh. Here we go. Okay, so I just wanted to give an overview of where we are at with the funding buckets, the changes from today, and under the bill that is in print today, what it looks like. You'll see there's been some additional changes. I'll highlight a few here. So under the bill now, just wanted to reiterate that under the 35% behavioral health services and supports, I call it the sort of catch-all bucket, at least 51% has to be spent on early intervention, 51% of that on children and youth, and they've added outreach and engagement to this category. That is a recent amendment. You may also recall that prevention, population-based prevention was moved to under the Department of Public Health. So that will be at least 4% of the state admin cap. At least 3% of the state admin cap will be for the workforce initiative. And in the amendments today, there is also an annual $20 million for the Innovation Partnership Fund that I'll discuss on the next slide, but that is a new addition. The 20 million is annual for fiscal years 2026 to 2027 to 2030 to 2031 and inclusive, and thereafter funding would be determined through the Annual Budget Act. Okay, major recent amendments. I'm going to try to do my best here and hit most of the major categories, but please note there are also additional amendments that we're still going through. So as I mentioned, there is a new component for innovation under the 35% catch-all bucket. Innovation will remain there too. The commission will also provide technical assistance to counties on any innovation they may do. But for this new innovation fund, the commission will award grants to private, public, and nonprofit partners to promote development of innovative mental health and substance use disorder programs and services. And the programs and services shall be designed for improving programs and practices for the following groups: underserved populations, low-income populations, communities impacted by other behavioral health disparities, and additional populations, and they shall be designed for meeting statewide BHSA goals and objectives. And they've added additional language where the commission would do a report on the programs and practices funded with this money, and also the extent to which they accomplish their goals. Reiterating here for early intervention, that is 51% of the catch-all bucket, with at least 51% of that for children and youth. They've added language that's in print today that community-based organizations and also community-defined evidence-based practices would be under early intervention. And they've added an additional goal for early intervention programs and services to reduce disparities. For population-based prevention, as I mentioned, this would now be under Department of Public Health, at least 51% dedicated to children and youth. New language added in print today says that programs may be community-led, trauma-informed, and include cultural affirming strategies. And they've expanded the priorities to include outreach and engagement for 0 to 5 out-of-school youth and secondary school youth, and can include partnerships with CBOs. Regarding substance use disorder, counties can now choose to provide SUD based on data and stakeholder engagement. The counties must use the data to appropriately allocate funding between mental health and substance use disorder. Regarding school mental health, they've expanded what school-based prevention programs include, listing out health centers, wellness centers, group coaching and programs to reduce stigma, provide mental health first aid, and mitigate suspension and expulsion. County integrated plans must demonstrate how they will utilize funds to deliver prevention and wellness in schools. And early intervention programs emphasize the reduction or likelihood of school suspension, expulsion, or referral to an alternative or community school, or failure to complete. And that's for 0 to 5 TK through 12 and higher ed. They've also added language regarding school mental health that these supports and programs shall be provided at a school site or arranged for by a school on a school-wide or classroom basis, and shall not provide services and supports for individuals. The outreach and engagement that was added to the 35% catch-all bucket is defined in the bill as activities to reach, identify, and engage individuals and communities in the behavioral health system, including peers and families, and to reduce disparities. Counties may include evidence-based practices and community-defined evidence practices in provision of these activities. Okay, moving on to more amendments. Regarding flexibility, there is additional flexibility in the bill where counties can shift funds based on needs. DHCS will review a county's request based on the county's demonstration that the requested shift is responsive to local priorities based on, at a minimum, local data and community input in the planning process. I can go over the shifts in the bill for 2026 through 2029. Counties can shift 7% from one bucket to another with a 14% max for all. And then that goes down for 2029 through 2032 with a 6% shift around per bucket and a 12% maximum for all. And then for 2023 through and ongoing, counties can shift up to 5% from one bucket to another with 10% max of shifting funds. Rural counties can receive exemptions. They've clarified that in the bill for housing exemptions. They must consider factors including a county's homeless population, number of individuals receiving Medi-Cal specialty behavioral health services or substance use disorder treatment services, and other factors as determined by DHCS. And for 2034 through 35 fiscal years, counties can apply for this exemption regardless of their population size, so not just the rural counties. And for FSP exemptions, the county has to consider factors such as county population, client counts, and other factors as determined by DHCS. They've also added language that counties will maximize rather than exhaust the use of other available funding like Medi-Cal or insurance before going to BHSA funds. Regarding the workforce initiative, there's new language in the bill today that a portion of the workforce initiative may focus on providing technical assistance and support to county and contracted providers to maximize the use of peer support specialists. And regarding revenue volatility and prudent reserves, there's new language in the bill today that creates a Behavioral Health Services Act revenue stability work group that will develop and recommend solutions to reduce revenue volatility and to propose appropriate prudent reserve levels to support the sustainability of county programs and services. That will be convened by Cal HHS and DHCS. Members include the Commission, LAO, CBHDA, CSAC, and they will consult Department of Finance. This will commence in June 30th, 2024 with a report due June 30th, 2025 with recommendations. A couple new updates to county integrated plans, which replace the 3-year plans. They've included that county should have goals to reduce disparities. They shall incorporate feedback from peers and families, and that they may provide support and trainings for meaningful stakeholder and peer and family participation in the planning process. The County Behavioral Health Outcomes Accountability and Transparency Report, which replaced the annual Mental Health Services Revenue and Expenditure Report, which is annually submitted to DHCS by the counties. They added language that metrics established by DHCS in consultation with the Commission shall be used to identify demographic and geographic disparities in programs and services. And then we've got some new language regarding implementation. The legislature can amend the act in certain circumstances. In summary, future amendments to the provisions of the bill could be subject to a 2/3 vote of the legislature, a majority vote of the legislature, or a majority vote of the legislature plus voter approval, and will require a case-by-case analysis by the Legislative Council. The Commission will provide technical assistance for implementation planning, training, and capacity building investments. And there's also new language where the state auditor will audit implementation of the BHSA every 3 years. The first report being due at the end of 2029, and then every 3 years thereafter, with the last report in 2035. The audit will cover the impact of policy changes on overall delivery of services, timeliness and thoroughness of guidance and technical assistance for the transition, implementation progress, progress towards outcomes and goals, number of people served, gaps in service, impact of the inclusion of SUD, effectiveness of county reporting requirements, and also coordination and collaboration among the state and local entities. And it will include recommendations for regulatory and statutory changes. Okay, I quickly wanted to go over just the impact to the commission because there's quite a few changes. You should have also received a handout where it goes even more in depth, comparing the commission today and the commission under the bill in print as of now. Just wanted to reiterate a few things. The commission will remain independent, shall receive data both from state entities and local. As I mentioned, it will administer the Innovation Partnership Fund and submit a report on that to the legislature and provide TA to counties on innovation projects. The bill has 11 new commissioners. I've got them listed out here. So 27 in total. The commission will consult with DHCS on a number of things, including FSP standards of care, early intervention, evidence-based practices, and as well as community-defined evidence-based practices, and the metrics to evaluate programs. And they will also consult with Department of Public Health on population-based prevention. The commission will additionally advise the governor and legislature on substance use disorder. The commission may establish a reducing disparities committee focusing on demographic, geographic, and other communities. That's new language in print today. The commission is also a member of the Behavioral Health Services Act Revenue Stability Work Group, as I mentioned. Also mentioned, the commission will provide technical assistance on implementation. And there's also a couple new reports under the proposed bill that the commission will do, including publishing recommendations for the state in collaboration with DHCS on data learned from the technical assistance, and also a robust community engagement process focused on priority populations and diverse communities. And a second report that includes recommendations for improving and standardizing promising practices for Behavioral Health Services Act programs in collaboration with DHCS, the Planning Council, and CBHDA. Okay, I know that was a lot. There's a lot of amendments, but I'm happy to answer any of your questions and do the best I can to answer them based on all the recent language.
Thank you, Kendra. So at this time, I would like to invite commissioners to offer comments or questions on the governor's reform proposal. And I'd like to invite Toby to join Kendra in responding to commissioners' questions. And to get started, I'd like to share where I stand. I have been with the commission for several years. We have seen considerable progress in our work for transformational change. School mental health has been embraced across the state in ways that I would not have imagined even 5 years ago. Public awareness for the need for suicide prevention is increasing, and our suicide prevention efforts are improving constantly. Stigma is down, and community support for mental health is up. We have made gains in early psychosis, youth drop-in, criminal justice diversion, and community engagement. At the same time, we have an addiction crisis, a housing crisis, a workforce crisis, and it continues to be too hard to access care when we need it. Too many families still must resort to calling law enforcement as a first response to unmet mental health needs. Disparities also are not trending toward equity. California needs to do something differently. And although I do not agree with everything that is in this legislation, it brings a renewed commitment to getting the job done, and it preserves our authority and capacity to making sure that that happens. At this time, I would like to open this up for discussion and ask if anybody has questions or comments regarding what we've just heard from Kendra. And so Toby, if you could log on and just work alongside us, please. Commissioners, if we could anybody who would like to start? Commissioner Brown, please.
Thank you. First a question, I guess, and then a comment. The question, Kendra, is with respect to implementation. What are the amendments that have been provided with the ability for the legislature to amend the act under certain circumstances? What are those circumstances?
Thank you for the question. I'm actually going to have Jeff help me with this answer since it's quite legal and we'll probably do a better job of explaining it. If that's okay, Jeff?
Sure. Generally, a commissioner and everyone, because this is an initiative, and to the degree that any of these provisions are part of the new initiative that go on the ballot, they need to go back to the voters for approval. And so that is the general standard that exists under these circumstances. The existing proposition, the Mental Health Services Act under Prop 63, has a special provision in it that says that the legislature, by a 2/3 vote, can pass legislation if it furthers the purpose of the act or makes technical or minor changes. So it depends, as Kendra said, on whether the language comes out of the existing Prop 63, because even though the Behavioral Health Services Act is very large and encompassing, it does not take away everything. There are still provisions that will be valid law that come out of the Mental Health Services Act. So it really depends, as Kendra said, on the circumstances of each situation as to whether or not the legislature can modify the language and then by what standard going forward. But generally, it's got to go back to the voters if it was on the on this ballot and this initiative is in fact passed this spring.
Great, thank you. And then the other a comment in advance of a question, I guess. I'm struck with the update and with the amendments by the number of additional commissioners that are being proposed. The original one, I think, had a handful compared to this list that we now have, and 27 people on a commission is an exceptionally large number, I would think, for a commission, and it's going to make it very difficult for business to get done, for discussion and agreement and so on. And I just am curious, and I don't know who this question's for, Toby or somebody maybe, if anybody knows, but is there any other commission for the state that has that many commissioners? Seems like an extraordinarily high number.
Thank you, Sheriff Brown. There are larger commissions. The California Planning Council is larger. Clearly, given the makeup of the new seats at the commission, you can see the level of interest and the areas that the governor and the legislature are really encouraging the commission to lean in on. So expertise around housing, for example, reducing disparities, SUD seats. So, while I share your concern about the complicating nature of getting a quorum and scheduling with 27 people, we've talked with the administration and encouraged them to perhaps elevate focus on those topics rather than more seats at the table. They felt very strongly that more seats at the table was important, and this is how it's being written at this time. To be frank, given the lateness of the hour, we don't see lots of opportunity to make adjustments there and feel like we will make it work. As we, it's only one time where I believe we failed to have a quorum, and that was when the Camp Fire in Northern California really, unanticipated emergencies called commissioners away, and we'll make it work with 27 as well.
Okay, thank you.
We also have Commissioner Chambers with their hand up.
Please, Commissioner Chambers and then Commissioner Tamplin.
Thank you. For Kendra or Toby, thanks for the analysis. I represent, as you know, peers, business leaders, consumers, stakeholders. And I'm just wondering, does the workforce amendment include anything to resolve the number of peer support services that are potentially lost with the reductions in the community supports and services bucket? Most, as you know, peer support organizations have funding under MHSA and do not currently bill Medi-Cal. So I'm wondering what solutions, if any of these amendments address anything, unless I'm seeing a whole workforce and services wiped out completely.
Thank you for the question. Not that I'm aware of, but I'm still reviewing the amendments. The workforce initiative.
Kendra, I think you're still on mute.
I hear her.
Can you hear me now?
I can hear her.
We can't hear you.
We can hear you.
Now
Okay.
we can hear you. Sorry.
Okay, so not that I know of, the workforce initiative language is really just one line that it was on the slide. There's no additional language. That being said, I would want to do a more thorough review of the most recent amendments, but it simply says that the workforce initiative may focus on providing technical assistance and support to maximize the use of peer support specialists. Nothing about Medi-Cal that I see.
Okay, so I just want to just be clear. It sounds like we have no amendments to address how peer support services are going to operate outside of MHSA funding. I mean, Toby, do you have any feedback on that? I'm just very concerned.
Yeah, I think, you know, while we recognize that the behavioral health reform as reflected in this legislation is massive, there are a number of initiatives here that really basically lay out an agenda and call for the state through various departments to push in those areas, right? Where the strategy, the specific either policy or practice changes that need to be put in place would come later. So, for example, this is very much tied to CalAIM and other reforms that the state is working toward. And, including the early psychosis work, school mental health work, there are multiple initiatives. The conversations that we've had with the administration are that the details matter moving forward, and that we would want the ability, and this is part of the conversations we've had with them in terms of the commission's jurisdiction and its authorities and the tools and strategies we can bring to the table. But the conversation is that the first step is to put this policy change forward, but it has to be followed up with intensive community engagement and conversations to ensure that the day-to-day work results in the outcomes that we want to achieve. And that includes figuring out how to make sure that our workforce needs are met with heavy emphasis on peer strategies, per Kendra's comments. So, not everything is being addressed in the statute. What it's trying to do is lay the foundation for conversations moving forward, as reflected in several instances where there's significant discretion on the part of DHCS, or in the case of workforce, HCI. I think, the good news is the state is really embracing the workforce challenge, as evidenced by the fact that the funds are being allocated at the state level. But there's more work to do to make sure that peer strategies are reflected in fiscal policy, in training, and in the practice implementation across the state, so that when people walk in for services, they know what to expect, and there's some consistency, and that includes, respecting peer roles from, Imperial to Del Norte, and every place in between. while that may not be satisfying, there's a lot more work to do is what that means.
And thank you for that. And sorry for taking up more space. So just to be clear on the record that the hope would be, this is your analysis, that we would we would have to wait for other policy like CalAIM and other initiatives to hopefully make some corrections, and that this bill currently doesn't address, the loss of funds of a whole industry.
You mean in terms of the service dollars that are shifted
Yes,
to housing?
MHSA, yes.
Right, I hear you. The good news is that that this doesn't take effect right away, right? There is a lag in terms of implementation and what the administration envisions. So our analysis is the intent here is that by enhancing access to federal funding, enhancing access to commercial coverage, improving utilization of Medicare managed care dollars, right? And clarifying how that these funds can be used for a broader array of services that Medi-Cal and commercial insurance, those other fund sources, is that there would be a net gain. But it's not clear how that's going to happen. It's going to take some time. Again, in our conversations with the administration, the first step is to put in place the policy structure that is necessary to be successful to tackle the challenges that have gone unaddressed for a long, long time. What's going to be really important is how we follow through on the implementation piece. So again, there's a lot that we don't know in terms of what kinds of federal approvals will come forward, how that's going to work. But our conversations are that we wanted to make sure the commission had a seat at the table and would be able to monitor and promote and provide technical assistance and really push. And with the most recent amendments, we've not just sustained the commission's jurisdiction and authority, so to speak, but enhanced them in some ways. And so Commissioner Chambers is going to take consistent attention on that issue over time.
Thank you.
Commissioner Champlin.
Thank you, Chair Madrigal-Weiss, and thank you again for Kenra and all the staff for all your hard work in bringing this presentation to us, and of course HHS and the state for being in conversation. I think it took a lot of advocacy to get to this point of conversation, and some of it feels again just a little too late, in my opinion. The piece that I think has been consistent about the challenges with this has been that, and it's been said by many before, is that we're in a housing crisis in California, and to take away MHSA dollars, as much as we need more focus on housing interventions for sure. So I wish there would have been additional resources that is consistent to support the services needed and continue growing the services versus chopping it up and moving it around and restricting kind of access to the dollars that are necessary for the services to happen, because the services do help. People are getting support, but we need more. We need a lot more. And to think about right now, what we're talking about is 17% of that 35% for behavioral health services supports is for a combination of workforce education and training, capital facilities and technology innovation, and prevention and early prevention piece is moved or is kind of missing in my opinion. And prevention is so huge, and that 35%, there's nothing in there that says prevention. Prevention looks like is at the state for population-based prevention. That prevention work needs to happen locally. It's been critical to our efforts to address and prevent people from going into crisis and creating more of our issues that we're facing right now. And so it's just hard to be here and to see something that was well thought through with the community originally and advocated by so many people here and across our state, to now see it, so many people advocating against it also, and concerned about these kind of policy changes and changes that have happened way too late of the game. Now we're in, like, you know what, 2 weeks or whatever, that to make a decision, and then going to the voters in March to vote on this. So I just, you know, I maybe the question I'm trying to get to is maybe I'm unsure about what the population-based prevention is, and if you can, Kendra or Toby, talk a little bit about that, that would be helpful.
I'm happy to, or if Toby, you want to chime in, go ahead. It's a pretty short section, so I'm just going to read you exactly what it says, because I think that might be the clearest way to explain it. So the population-based prevention was moved to the state level, to Department of Public Health, to provide population-based mental health and substance use disorder prevention programs. Of these funds, at least 51% shall be used for programs serving populations who are 25 years of age or younger. The programs and activities are designed to reduce the prevalence of mental health and substance use disorder and resulting conditions, and shall incorporate evidence-based practices and community-defined evidence practices and meet one or more of the following conditions. Target the entire population of the state, county, or particular community to reduce the risk of individuals developing a mental health or substance use disorder. Target specific populations at elevated risk for mental health or substance use disorder. Reduce stigma associated with seeking help for mental health challenges and substance use disorders. Target populations disproportionately impacted by systematic racism and discrimination. Prevent suicide or overdose. They may be implemented statewide or in community settings, and they may be community-led, trauma-informed, and include cultural affirming strategies. They shall not include the provision of services and supports for individuals. And then they also have that school-based language that I mentioned before.
Thank
so
you.
That's pretty much the whole section of how they're describing it. In terms of analyzing that and saying what it means, I would leave that up to the administration, but that's the language in the bill.
Thank you. No, that's really helpful. Again, very concerned that prevention is moved to 4%, and we do stigma reduction campaign locally in Alameda County, and that sounds to me like our local money is going to the state for a statewide effort and reducing to 4% across the whole state. So I'm just concerned for the local county's ability to meet the needs of prevention that is necessary for helping people stay out of the hospitals and get the supports they need before it turns into crisis. Thank you.
Thank you, Commissioner. Commissioner Bunch.
Hi, thank you guys again. I just reiterate, thanks. This was a really great explanation of everything. I had a comment and a couple of questions. I just wanted to reiterate Commissioner Brown's questioning of the 11 more commissioners. I feel like we've done a lot on the commission. I've been on since 2018, and I feel really fortunate to have been a part of everything. But I know a lot of things that happen are around scheduling for a big group of really busy people. So adding 11 more, I think, is just going to add on to that very logistical concern. My other question is around, and I read through it again, and I don't know if I'm missing it, but about any kind of specific evaluation period. If there is one, if there isn't, can there be one, just to, at the very least, see if there's any unintended consequences of the housing set aside on mental health
do you mean evaluation by the state, I guess? There's a couple different ways they're evaluating the effectiveness of the programs and services. I think it's through the county planning process, but also the reports, the data that counties have to send annually to DHCS, which DHCS then publishes on their website. And then I also think it's through the state auditor, which would be every 3 years. That'll be kind of an additional way they're trying to evaluate implementation and the effectiveness of the programs and services, including the new housing bucket.
So what would be the next or the first kind of way that they're evaluating? What's the timeline around it?
I'll have to look as we're talking because there's so many different effective dates. But my guess is since the funding bucket section would go into effect July 1, 2026, I think it would start probably after that. Toby, any thoughts on that?
Well, and I just want to add that the language preserves the commission's independent authority to take a look anytime it wants to at the implementation, on top of the regularly scheduled audits that include audits of our own work. And interestingly, there's a component that the audit is also to look at the extent that there is a high level of collaboration between the commission and in the Department of Healthcare Services and HCI and some of the other participating departments. And that's also on top of the sort of renewed accountability. So, while there are some programmatic dates in terms of taking a look to see how things are working, there's also the commission has the authority to dig in as you see fit, including being able to comment on some of the things that should be happening along the way, between the date at which a measure is put on the ballot, should it pass, and the actual implementation dates, just to ensure that we're laying the groundwork for success.
Okay, thank you. I know there's a lot of questions, so I'll stop there.
Thank you, Commissioner Bunch. Commissioner Rolette, please.
Thanks again. I certainly agree with the staff, has done a great job in putting this matrix together. I also want to acknowledge that there certainly is a crisis as it relates to unhoused human beings in our wonderful state of California. I don't believe a disproportionate number of those individuals are homeless because they have an untreated mental illness. Now, that certainly may be my opinion alone. I think that there is a unique housing challenge in California that has to also be addressed. That includes for people without symptoms associated with mental illness. That's my preamble. My specific questions are related to the first statement, there's no oversight role. And as I look at this, it seems a bit counterindicated that the Oversight and Accountability Commission, we would not have an oversight role. That's what we are supposed to do. We're an independent commission with oversight responsibilities, especially as it relates to the delineated list of bullets under the no oversight role statement. And so I have concerns about that and what recommendations you might have for us as individual commissioners, or what recommendations you might make as staff as it relates to this, because I do think we should have an oversight role. Number two, specifically, and for staff, and again, Kendra and Toby, this might be getting in the weeds a bit. As I understand funding for existing outpatient services, it comes under the category of General Systems Development, or GS funding, and that discretion is still there. However, with the categorical funding for housing and other services being identified by the administration, my concern is that the impact on the existing outpatient system will be very deleterious and is not being talked about. that in many of the counties that where we're privileged to provide services, the Mental Health Service Act funding does fund a number of, certainly from the county and stakeholder perspective, important outpatient services. And I don't know if you have a perspective about that and that impact, which isn't talked about very much. So 2 parts, 2 questions.
So on the first one, so in the latest round of amendments, while it did not recreate the existing statutory language, it reaffirmed the commission's oversight role in some ways a more expansive statements through our capacity to promote transformational change, to undertake reviews, to recommend progress, make change, and it references the Behavioral Health Services Act and related, anything related to behavioral health. So in terms of your first question, while the legislation originally did eliminate the statement that says we have oversight over the adult system of care, the children's system of care, and the older adult system of care, at least our interpretation of the new language is that is preserved, even though it is written in a different format. In terms of the second question, that's a harder one to respond to because we won't know what those changes will look like in terms of access to outpatient services because of the package of reforms that are reflected here, both in terms of new Medicaid waivers, in terms of access to commercial insurance, the standards that DHCS would put in place for care, and even the language around early interventions. So there is some uncertainty here in terms of the impact that it would have on our ability to provide traditional outpatient care. Unfortunately, Commissioner, as we have raised in the past, we don't have a program by program analysis showing what that would look like in terms of areas where there may be more revenues and areas where there would be less revenues available to cover care.
Appreciate the answer, and just one follow-up statement. It would be helpful if you could, as one specific action, get clarification on what the specific oversight role of the commission, what the intent of the language is, and to be clear about that so staff can be clear and you can communicate that to commissioners, especially given the larger nature of the commission. It certainly makes sense that would be clear. And then if it's possible to make some projections or do some illustrations that might suggest what the impact could be, either positive or negative, as it relates to some of these changes around existing services, the existing service array, that would also be helpful.
Well, I can share with you that in the conversations we've had with the governor's team and Secretary Ghali, he's very explicitly stated that he does not see our role as a compliance role, that is falls into the more traditional role of the Department of Healthcare Services in terms of the existing performance contracts and audits and reviews of Medi-Cal policy and so forth. But what he has also said is that he sees the commission's role as really pushing this broader strategy around how we get to where we need to be in terms of ensuring everybody who needs care gets care in a way that is cost effective. And so bigger picture than compliance, really thinking about oversight as driving quality, driving access, creating the kind of things that we've done, creating incentives to ensure access to early psychosis care, for example, and really pushing for the state and the counties and related partners to get better at care delivery. I think on the second issue, the conversations that we've had with them really are about how important it will be for an implementation strategy to ensure that the reforms actually result in the kind of outcomes that you're concerned about, right? That we don't end up pulling so many dollars out of care delivery in order to respond to housing that we're just left with a very different catastrophic challenge. And so the language in the legislation calls for the commission to provide consultation on what early intervention means, standards around FSPs, and to really provide TA and assistance and support to ensure that, in fact, these changes have the positive outcomes that is intended. But want to recognize that we haven't done the homework on the front end to ensure that the likelihood that that happens is higher than lower, which means we have to work harder during this early implementation phase to ensure that the rollout is done in a way that will be effective. And we raised that issue in our initial analysis around a transition plan. And so I think there's even if this passes the legislature and gets voted in by the voters, there's still a lot of work to do to make sure that the implementation is done in a way that has the impact that you're so concerned about. The good news is the commission very much can be in the middle of that conversation.
Thank you.
Chair, this is Commissioner.
I'm sorry, Commissioner Carnevale.
I'm good.
Commissioner Mitchell, did you want to say something first? Go ahead.
Yeah, just quickly, because I do have to log off. Just again, coming from representing families, I just would like to know if there's any conversation, as basic as it may be, in terms of the implementation, as Toby mentioned, to get to the place where we want to be with care delivery dollars being moved around. Is there just any conversation regarding making access to care simpler for families to obtain? I think that's just the biggest issue for me with all of it. When families are in crises, families just need to know, where do I go? How do I get there? And so if there's any space for that type of conversation to occur, where we are really looking at systems change that make it just easier and simpler, one-touch dial to get to where we need to go when we are in crises. Because at the other end of all of this are families, and counties have to develop whatever that looks like to make it simple for people to get care.
Commissioner Mitchell, part of the conversation, thank you for the question and for putting that in such simple terms, right? And consistent with one of the public comments that Emily made about building trust of this system, right? That success, we found success when clients and families know where to turn. It's simple, and turning to these services is with a high level of trust and confidence, much like we see in other aspects of healthcare. Part of the conversation that we've had with the administration around the importance of an implementation strategy is we've asked them, how might the commission support, identify some of these areas that we could lean in on to ensure that implementation was done in a way that is, aligned with where the community is, right? We have a history, a reputation of doing community engagement. We can certainly bring that skill set to this conversation, and I think that would be a sort of the right opportunity, right? It's not about compliance, it's about transformational change.
Thank you, Toby. And Chair, I have to sign off.
Thank you, Commissioner Mitchell. Thank you for being here. I have Commissioner Carnevale, then Vice Chair Alvarez. Please.
Thank you, Madam Chair. I think I feel the way probably most of the commissioners do. This feels like an impossible decision from our perspective because there's so many good things and there's so many challenging aspects of this proposed legislation, and a lot of it's still half-baked. But what I have heard from the governor's office and from Secretary Ghali is that they understand these issues. They are thinking about them in a broader context. They have plans and commitments to work through them. They have changed their opinions based on our input. And I guess what I do know is that this governor and this administration has been more aligned and sensitive to a lot of these issues than any previous administrations that I know of, notwithstanding the fact that there are still massive systemic issues, which has predated this administration and will no doubt continue. But that leans me in the direction to say that the commission we have to understand our position, and our position is that we don't run the government. We are a small but very important voice, probably outsized voice in this system compared to the resources that we have. And that's good. But there are much larger entities, the governor, HHS, and others that are thinking about this with a broader context. And so I choose to believe that they are going to make decisions that don't hurt people, even though it feels like they're going to, given this direction. And I would just say, on a positive note, they understand our transformational position in the system, and they're embracing that. And I would just say my experience on the commission is the most valuable thing we do is we allow voice in the system from all the constituencies, and I sympathize with all of them, and I share their concerns and their fears. And I would say, shout loudly and use this commission to hear your voices, and we will fight hard before, during, and after to try to make those voices heard and impact policy as much as we can. Thank you.
Thank you, Commissioner Carnevale. Sentiments exactly. Vice Chair Alvarez, please.
Thank you, Chair Madrigal-Weiss. I will follow Commissioner Carnevale's comments with a very similar tone. I want to deeply appreciate the incredible amount of work as well that went into getting us to this position. I want to also really reiterate, Chair, where you kicked us off, your opening comments really did acknowledge this tremendous opportunity in front of us to modernize the Mental Health Services Act. It's been almost 20 years. I think none of us are opposed to discussing what the opportunity is in front of us to really look at the Mental Health Services Act and what we can do with this tremendous amount of resources moving forward. And it is these, roughly 2 decades that I think give the commission and the counties and stakeholders such important information and lessons learned about what we can do better to serve people and to prioritize their mental health and well-being. And I think it's because of the work of the commission and the work of many advocates, community leaders, local partners, many of the stakeholders that we see at our meetings on a monthly basis, that the language in front of us has significantly changed. It's got greater attention on children and young people. It strengthens the role of this commission, completely different from where it was. It gives attention to innovation. And I want to really just extend deep appreciation for all of the work and advocacy that went into evolving this language, and also to the commitment to partnership from this administration and the department to find ways in which we could evolve this language in order to, again, give credit to the incredible amount of work that the Mental Health Services Act has done in these 2 decades. I want to speak a bit to this importance of prevention that Commissioner Aslami-Tamplin highlighted. I think there has been a great amount of attention placed on the need to prioritize prevention and early intervention, and want to continue to encourage the administration to consider how we can continue to focus on upstream prevention activity that does not require a diagnosis for children, but that also allows services to be given to children at the county level. We are so encouraged by the language evolution that we see in front of us, and look forward to continuing to emphasize the importance of prevention in this work. And then I also want to give attention to the ongoing role of the commission and the commitment to partnership with the Department of Healthcare Services that has evolved over certainly the course of my time on this commission, but also it will need to further evolve as we try to create one system of care for Californians. That's what we keep hearing about with this modernization. How do we improve this system so that at whatever door you come in, a Californian is going to get the services that they need to support their mental health and well-being. And Toby, I think it would be really helpful to hear a bit more about those shifts, in particular in the attention to the commission and the partnership between the department and the commission, because that's the work we're doing. The stakeholder engagement, the projects like school mental health and violence or peers, like that is critical work that I think the commission brings an incredible amount of partnership and leadership to the work ahead. And I think it would be really helpful to hear if you could talk a little bit more about that role and opportunity as a result of these changes. It would help me in the work ahead. And I do think for the stakeholders that are on today, hearing more about that would help inform the decisions moving forward.
I think my best response to that would be to invite Secretary Gali to come and talk with the commission, to lay that out and have that dialogue with you, so that, as was mentioned earlier, to create some clear expectations and ensure that the lines of communication that have been established through this process, remain open. I think he's in a better position to answer that than I am, if that's an appropriate response, Madam Vice Chair.
I think so. I mean, if I'm not mistaken, Toby, this opportunity today is to ensure that the commission remains a committed partner in the work moving forward. But we're not even close to being done, right? These discussions, this engagement is going to be that much more robust moving forward in order to hold all of ourselves accountable to what the promises of this Behavioral Health Services Act is. And what I hear you saying is that let's encourage our partner in the secretary to demonstrate that as well.
Absolutely. Thank you. You said that better than I did. Appreciate it.
Thank you. Thank you, Vice Chair Alvarez. I have then Commissioner Gordon and then Commissioner Robinson. Commissioner Gordon.
I'm trying to unmute him. Let's see if this works.
He's muted.
Sorry, Commissioner Gordon. We're working on it.
You should be able to mute on his end.
Commissioner Gordon, do you want to try on your end, sir? Okay, here we go. Okay, it seems like we're still having trouble with Commissioner Gordon. I'm going to start with Commissioner Robinson, and then we'll come back to you.
Can you hear me now?
Oh, I can. Yes,
Oh,
I can, sir.
okay.
Go ahead.
Okay, thank you. I'm with the chair and Commissioner Carnevale. I think the efforts of the administration have really been extraordinary. In my memory, as a member of the commission for a long time, I found the commission full of knowledgeable, astute leaders, and a lot of the innovation work that was done and proposed and carried through and carried on has been extraordinary. Times change, as Commissioner Alvarez said. This is a new time, and I think we're not smart to let the perfect become the enemy of the good, because this is a work. It's a work in progress. I've had the opportunity to work closely with many of the governor's staff people, and they care a lot. They're in this for exactly the right reasons, and they want to make changes that will enhance opportunities for healthcare for every individual in California. I'm concerned most about prevention and early intervention, because I think that's our only way out of people dropping into the criminal justice system just because we haven't seen them early enough. We haven't seen them when they're between ages 0 to 5. We haven't used the opportunity that schools are in everybody's neighborhoods. Kids show up there every day. Those are places we could do screening, we could do more treatment, we could sell the notion of wellness and prevention. So I think we have a long way to go. But I think the efforts the commission has made have been an extraordinary change in what's already been going on. And I think we have to keep that momentum going. And I think the governor's initiatives are something we should work with. My only other concern, apart from prevention and early intervention, is that the commission really have the opportunity to be independent, so that we're not chained to the administration or the system, and that the commission continues to, and that's what I wanted to ask Toby to comment on, that the commission still has an open opportunity to comment on the state of change and the state of progress. And if the housing money is taking out too large a proportion of money that's needed to really move the system, that gets called out, and the state has an opportunity to make that right in the spirit of the original commission mission, and because I think this is a calling for most of us, for all of us, and again, I want to go back to I'm so impressed and grateful for the people who've been on this commission over the time I've been on it. That your service has been extraordinary, and Toby, you and your team have done a marvelous job. But reassure me that the commission, as we move forward with this, in collaboration with the administration, will be open to our criticisms, not as criticisms to put things aside, but criticisms to make it all better. Thank you.
Yeah, be reassured that the language preserves the commission as an independent voice that is advisory to the governor and the legislature, and the authorizing statute explicitly directs the commission to call out whether or not sufficient progress is being made in terms of the kinds of goals that you decide, that the commission decides are important. So 100%, Commissioner Gordon, thank you.
Thank you, Commissioner Gordon. Commissioner Robinson.
Thank you, Chair. I do want to also acknowledge the work that's done to pull these documents together. It's been very helpful for me as a new commissioner. Also want to say that as someone who's lived in Georgia, Tennessee, North Carolina, I'm really proud to be in a state that recognizes the importance of mental health. As a mental health provider, lived in a lot of other places where I did not see this level of commitment to trying to address the behavioral health needs of the citizens. I do want to start by saying I share Commissioner Rollett's concerns as the newest commissioner, going from a committee that clearly had oversight. I mean, it's kind of written in the language to there's no oversight role. I do want to understand that and kind of that kind of clear, succinct language and language doesn't matter. So saying no oversight role, that does concern me some. The other, this is probably more of a question. I see that we are now a member of the Behavioral Health Services Act Revenue Stability Work Group. And what does that mean exactly? Are we a voice among a lot of other voices? Do we have any oversight or leadership role in that? Because for me, revenue stability is key to making this act be effective. And then the last question is for innovation, which I think is one of the most compelling aspects of the commission. We go from overseeing innovative programs to administering the innovation in partnership. So can someone maybe comment on those aspects? Because language does matter, and I want to make sure I understand it a lot better as we move forward. Thank you.
Thank you, Commissioner. So in terms of the oversight, while the words have changed, the kind of the functional ability of the commission to call it like you see it remains. It does clarify that, the administration has used language around it's less about compliance and more about, driving quality improvements, in terms of the kind of work the commission has been doing. And so, we don't see any functional difference between what you could have done before and what you will be able to do in the future. In terms of the revenue volatility, one of the issues that has challenged the Mental Health Services Act for a number of years is prudent reserve standards. And the tension is between putting a higher percentage of resources into a prudent reserve to weather a downturn in revenues at any point in time versus having those revenues available for use. And so the language calls for the formation of a work group to help figure out how to do that in a way that finds that good balance between an appropriate rainy day fund and appropriate access to revenues, recognizing that there are significant unmet needs that are out there. And so we're a voice on that work group, but again, the commission has the independent authority to express itself should whatever resolution come out of that be inconsistent with the commission's perspective. In terms of innovation, the innovation component of the MHSA has evolved, where although the dollars were held by the counties, the commission was increasingly identifying investment opportunities and working with counties. Often we funded the development of innovation proposals, but the doing work was funded by the counties. And we continue to do that to this day on full service partnerships, for example. And so, what the administration envisions is between the Mental Health Wellness Act grant, which is $20 million, which we have been using as incentive funds to encourage local partners to adopt effective practices, and now $20 million in innovation funds will allow us to sort of work both ends of that conversation. How do we learn what is effective, and then how do we incentivize it? Want to recognize that the dollar commitment is far lower tomorrow under this act than it was today. But I think the language is reflecting the conversations we've been having with them about the importance of innovation and the opportunities to leverage the collective voice of what will be 27 commissioners to really recognize how innovation can be important. I also want to point out that somewhat new is this push to really leverage the private sector and others outside of the behavioral health sector to support innovation in ways that can really be driving quality at a systems level. So it's not apples to apples in terms of the counties had the dollars we were approving and now we would have these funds. It really is sort of an expansion of the opportunity that the innovation dollars represent, with direction that you all would decide how best to use that investment. I hope that answers your questions.
Thanks, Tony.
I have Commissioner Brown and then Commissioner Danovich, please. Commissioner Brown, I don't hear you still, sir.
Okay, now I got you.
Yes.
Thank you, Commissioner. Thank you, Chair. I just wanted to add a few comments. In my earlier statement at the very beginning of this, I asked some questions and voiced some concerns about particularly the size of the commission as amended. But I just wanted to sort of just clarify a couple of things and go on the record about that with my fellow commissioners. My feeling is that this is a very bold and in some ways risky proposal to fundamentally change the Mental Health Services Act. It proposes significant change. Change in and of itself is usually painful for organizations and for people, but great accomplishments, don't come along without change and without some risk. And oftentimes without some grievance. And I know that there are many organizations and individuals and advocates who are concerned, and I appreciate those concerns. I've been listening to them, those that have been directed at the governor's plan. And as you heard, I have concerns myself about the significant expansion of the commission size and our ability to conduct our business as a result of that. But on balance, I have to give credit to the governor, great credit to him, actually, for a bold approach to address two of California's most vexing problems, homelessness and substance abuse, each of which often exists in concert with and exacerbates mental illness. In my county alone, a county of 450,000 people, we lost 163 people last year to fatal overdoses. And this year, we are on track to exceed that number. We are in the midst of a crisis, and something other than the status quo really has to be done about it. The governor's plan, I think, is an opportunity to modernize the system and address the extraordinary size and scope of the two perplexing problems of homelessness and substance use. Just like any other proposal to solve difficult problems, the plan is not perfect. And since Commissioner Gordon stole the line I was going to use about perfection being the enemy of the good, I'll just end my comments with a quote from General Omar Bradley, who once said, "A good plan enacted swiftly is better than the perfect plan enacted too late." And I think the time has come for us to embrace the boldness of the proposal at hand. Thank you.
Thank you, Commissioner Brown. Commissioner Danovich, please.
Yeah, thank you. I guess I first just want to express appreciation for all the comments of my fellow commissioners. I think that the range of concerns and the grappling with complexity and the perspectives that have been articulated really speak to the strength of our commission. And I feel very privileged to be a part of you all as colleagues. I also really appreciate the concerns that have been raised by the many stakeholders that are a part of this meeting, and the very real and legitimate fears and worries about how so much of what we have achieved and they have achieved is going to be maintained. And also really appreciate commission staff who worked so closely with this administration and with the Department of Healthcare Services to really significantly alter, modify, improve the legislation that we now have before us. So I won't go through all of really just to repeat concerns that others have shared, and Commissioner Brown, thank you for highlighting the substance use piece, which is close to my heart, as well, among our many, many priorities. I would just add one other thing, which is for us to fulfill our ultimate mission, one of the areas that we've always struggled is improving our alignment and cooperation with DHCS. Getting DHCS to cooperate more with us, to be more transparent, to enable us to help them do the things that we want to do together. And I think that's more written into this version of the legislation as I see it. And I think it's being manifest more by the leadership of DHCS communicating with us and expressing commitments to do that. And I think that cooperation is necessary to really manifest a systemic change that we all want to do, and that continues to need to be done. So notwithstanding the many concerns and the risks, I'm ultimately supportive of us moving forward with this.
Thank you, Commissioner Danovich. Commissioner Rolette, please.
I wanted to take a moment to acknowledge that I always appreciated diversity of opinions, and recognizing that certainly as it pertains to the existing service array, my questions or even concerns about the implications there were noted by Toby, and that while staff has not had an opportunity to look at what some of the implications might be as it pertains to the expansion of services to include people with SUD issues and problems. And I completely agree and endorse the comments that were made by my two fellow commissioners regarding the importance of that. I also recognize that even now that there are stakeholders who are emailing and saying, we have concerns about existing services and our services that are working, services who have achieved the outcomes that the commission endorses, services that include and inculcated features of community-defined evidence don't summarily go away in this change. And so I hearken to those services because I get to see them sometimes. I get to experience them a lot of times. And a lot of times I believe that the engagement strategies that work, particularly in communities of color, and especially the Black community, which is in Sacramento County, overrepresented in the unhoused count, recent unhoused count. Specifically, 40% of the people counted in Sacramento County were identified as Black or African American, only comprising 10% of the population. Commissioner Brown is absolutely right. We have a horrific problem. We've got to fix it. And I appreciate the attention that's being given without disparaging the people that are experiencing the blunt end of the problem. And that community-defined practices have done amazing things to engage and ameliorate some of those challenges. And so my voice of advocacy and support as it relates to those services and programs is one of experience, and one that, again, I hope that staff will provide us with some potential illustrations that could look at what some of the downside, because there is always a cost and a benefit when you expand the number of individuals that are being served. There's a great benefit, but there is that potential cost. And I look forward to hearing more about that from our staff. Thanks very much. And I appreciate this discussion very much.
Thank you, Commissioner Rolette. At this time, I see no other hands raised regarding questions or comments from my fellow commissioners. And I really want to make sure that we hear from the public. So at this time, members of the public may request to make a public comment on agenda item 8 by clicking the raise hand button on your computer or the app, or if calling in by phone, push *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. I would ask that we limit the public comments to 2 minutes because this meeting is due to go till 4 o'clock and we are going to lose commissioners. So I would respectfully request that we go to 2 minutes so that we can still have a quorum by the time that time arrives. So if we could please honor that. So 2 minutes. Mariani, please open the line for public comment and agenda item. So let's start with public comments now, Mariani.
Okay, we currently have 16 public comments. Our last public comment is Laurel. Our first public comment is from Sean. Your line is open.
Yes, hi. Yeah, many have shared that the potential of unfunding the safety net, so to speak, that exists due to the many MHSA-funded peer support programs will likely be devastating. The robustly choiceful, no wait list services are life-saving for many and help keep some folks out of higher levels of service, and for others help support them with connection and community to get into higher levels of services and offering a full continuum of care for folks. So many of these services are what is right with the system, and unfunding them, as a peer recently shared at fellow peer shared at a meeting I was in, is like selling off the fence at the top of a cliff to pay for more ambulances down below. It's like we got a fire and have to throw something on it. Just make sure it's not flammable. You know, I continue to hear from folks, they wish that this was only a good plan. Many have shared if it would pass, the loss of hope, trust, community, and connection is of great concerns, and folks pretending that Medicaid billable peer support can or will replace these services is unrealistic. I think there's a great need and a great place for the Medi-Cal billable peer support, but not instead of these more choiceful services that are working, that are the safety net. And I hope communities across the state can recover from this and the erosion of trust should this come to pass.
Thank you, Sean.
Thank you. Our next public comment is Tiffany. Your line is open.
Thank you. Excuse my voice. I want to thank the commissioners for taking this extra time to consider what it is that the Behavioral Health Services Act would look like. I am very concerned still. We hear about the lateness of the hour from Toby, about how there's a lot more to do. It's going to take time. We still don't know what the housing portion of this is going to look like. We don't know what this is going to do exactly to peer support within our state, although we do know that there are places that are already talking about defunding peer support positions. When we are looking at this, I don't understand the quickness that we're taking, the speed that we're going at, and I haven't heard any input, even though this has been raised time and time and time again about why we're going this fast. We talk about nothing about us without us in the peer community. We talk about that, and it isn't supposed to be an afterthought. It isn't supposed to be nothing about us without us, but pass things and then get our input. We should be at the front of this table, having our voice heard at the beginning. And so I would implore everybody, what is the speed here? Why are we going this fast? And why not take the time right now to get robust peer input while we can make that big difference? Thank you so much.
Thank you.
Thank you.
Next we have Patricia. Your line's open.
Thank you to the commission for having this opportunity for the public to comment. I am a mental health advocate in Sacramento County. I happen to be appointed to the mental health board here, but I'm not speaking on their behalf. In Sacramento County, our Behavioral Health Services Department has advised us that they expect to see a 65% reduction in the funding available for outpatient and crisis services in Sacramento County if this bill goes as it's currently standing. Even if we use the 7% flex option that's been written into the amendments, it would mean that our full service partnership would drop from currently 38% of funding to 28% of funding. And even if we took 7% from the housing bucket as well, it would still only increase our behavioral health services bucket, the services bucket, from 17% to 24%. It is not going to fix the problem with defunding the services that currently are being offered, and that include things like non-billable Medi-Cal services, such as case management services that help people maintain the housing that they have now. So the potential for there to be a new wave of people with severe mental illness becoming homeless because they have lost the services that help them maintain that housing is real, in my opinion, and based on my conversations with our local behavioral health services department. So I have grave concerns about the issues that Al brought up. And in Sacramento County, the current requirement that only 25% of the housing bucket be allowed to spend on capital development is an issue here because we're already spending that much money on capital development now from our full service partnership funds. So we would not be able to build anything more than we're already building. And we have a 3% vacancy rate in Sacramento County. So there is no property to rent or lease.
Please wrap up your thoughts.
I will. So thank you very much for taking this into account. I urge you to consider a no.
Thank you, Patricia.
Next we have Karen. Your line is open.
Hi, yes, thank you. Karen Vicari on behalf of Mental Health America of California. MHAC is opposed to SB 326 for a number of reasons. I don't have time to mention them all today. But I want to address two of our main concerns. And one of them is, as was mentioned many times today, while SB 326 does not specifically cut programs, a loss of funding for mental health services absolutely will result in a reduction of services. We've heard the state, and today we heard Toby saying that with all the new programs the state's coming out with, CalAIM, BH Connect, CYBHI, there's more. There's going to be plenty of funding for community-based services, right? But nobody knows what the state's landscape is going to look like once all of those programs are implemented. The MHSA was intended to fill gaps in the system. And until those programs take effect, we don't know where the gaps are. We can't write an effective modernization of the MHSA until we know what the system is going to look like. And the other concern we have that I'm going to mention today is the stakeholder engagement process. 9 CCR 3300 requires training of county staff and stakeholders. SB 326 makes this optional. Welfare and Institutions Code Section 5892 requires counties to pay for the costs of consumers and other stakeholders to participate in the planning process. This has been entirely removed from the MHSA. The planning process also is now every 3 years instead of every year. The planning process is essential to the success of the Mental Health Services Act, essential to know what the needs are at the local community. And I just want to add that it really saddens me that we've heard words today from commissioners like half-baked, risky, work in progress. Something this substantial should not be rushed through the process. We urge the commission to vote against supporting SB 326, or at the very least, remain neutral. Thank you.
Thank you.
Next, we have Susan. You can go ahead.
Hello, commissioners. Thanks so much for having this forum today. I'm Susan Gallagher, Executive Director of Cal Voices, and looks like a lot of people got concessions in the amendments, but guess who didn't? Clients, consumers. They haven't given us an inch in this, and we look to you commissioners to stand in the gap for us. There's no way in hell that this doesn't disrupt services for at least 250,000 people by shifting so much money away from the CSS bucket into housing. Honestly, the state of California spent $20 billion on housing in the last 3 years. And the state auditor is in the process of auditing that funding as we speak. But until we figure out where that money went, why would we take MHSA and fork over all of that money to them? What if they're not spending any of this money well? I mean, you're the commission. Come on, this should matter. And until I see that audit, I wouldn't give them one penny of MHSA funds. Secondly, we asked for mandated peer support throughout this continuum of care, that folks would be eligible and to receive mandated peer support services, whether they're Medi-Cal certified or not, that throughout the continuum of care, this be embedded throughout our system. Peer support is part of the equity lens, inclusion of those of us who've been disabled with mental health conditions. Like, this is so vitally important. And the state of California has a really crappy reputation for employing peers. We're at like 9%. The rest of the country is between 14 and 20%. And that's according to SAMHSA. So we need to do a better job at employing our clients and expanding the peer workforce. And we've been left out of this discussion. And so for all of you guys to make deals with the administration without any of us being at the table or really bringing us to the table, because we've had to force our way to the table and it's felt pretty awful. It's really been traumatizing. And I think all of us are just heartbroken that our MHSA is going to go away, and we relied on you to stand up for it. Daryl's already folded. We really were looking for the commission to stand up, and I really hope that you oppose it. You know, I want to also say that bringing all these commercial insurers like Medi-Cal managed care into our specialty mental health system, it's problematic. They don't come under any of the MHSA guidelines. They don't come under the mental health boards. There's no authority. Their authority is only to insurance companies. So you really have to think this through. This is a bad plan. Thanks for listening.
Thank you, Susan.
Next, we have Stacy. Your line's open.
Hello, Commissioner Stacy Hiramoto again with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. First, I do want to acknowledge that the administration did take many of our suggested amendments regarding reducing disparities, and we are extremely grateful. Unfortunately, I did not realize that the bill had been amended until this morning. And so I have not been able to analyze the bill completely to see if my board wants to change their position or not. But I do want to also thank Commissioner Alvarez for talking about upstream, because this is one of the issues that we wanted to focus on upstream, because no, the Mental Health Services Act was not only just for people with serious mental illness. Of course, the majority of the dollars should go there, but it was always for prevention and upstream. And we were trying to make it clear that community-defined practices could be utilized in both population prevention and early intervention, and they are working towards that. Although we did want them to say that for early intervention, you did not need to have a diagnosis. I don't believe that language was taken, but again, they did move, and we're very, very grateful. I also wanted to thank Commissioner Rolette for acknowledging the value of community-defined evidence practices, because I believe we were successful in getting that into the bill too. So I just wish the commission, I think it's hard for you to take a support when the amendments just came out and there are so many issues. So that's all I wanted to say, but thank you.
Thank you, Stacy.
Next, we have Tara. Your line is open.
Good afternoon, Chair and Commissioners. This is Tara Gamboa Eastman with the Steinberg Institute. Just want to thank you for the rich discussion, as always. We are incredibly excited about this proposal. Obviously, our founder, Mayor Daryl Steinberg, was instrumental in the passage of the original MHSA, and we really see this as an opportunity to tap back into the inspiration and the origins of the MHSA, focusing on folks with serious mental illness and substance use disorders who are also experiencing homelessness while still preserving critical prevention and early intervention dollars, and addressing some of the systemic issues regarding outcomes and accountability that we think will just lead us towards continually improving the system to best meet the needs of Californians. We're incredibly excited about this proposal, happy to be in support, and hope the commission will take a support position today. Thank you so much.
Thank you, Tara.
Next, we have Claire. Your line is open.
Hi, good afternoon. My name is Claire Courtright. I'm Policy Director for CalVoices, and a consumer and a person who benefited and whose life was saved and changed by the MHSA, which provided me services when I did not have insurance, was not eligible for it initially. So, you know, I just want to level set on something, which is that to my casual observation, no one is truly in favor of this bill as it stands. And I think the commission should come out in an unequivocal opposition to it and do so today. And we're disappointed that you have not done so already, but I think everybody's sympathetic to the fact that there was a great deal to digest here in order to comment on it intelligently. But we're 2 months out from the LAO's analysis, and the administration has yet to respond to any of the points raised by the LAO, by the counties in these hearings, or by clients. We know it's mathematically impossible that services don't get cut. Yep, Sac County said it, Nevada County said it. We know it's a massive cut to services, and yet no one in the administration has offered any analysis, any data, or even a plausible argument as to why moving from MHSA as it currently exists now to 326 is an improvement. You know, how and why would it result in better services, more satisfied clients, or better outcomes? And the human toll of cutting services is entirely foreseeable, and it ranges from destabilization to loss of life. So, the bill is bad policy and there's no time to reform it because the administration chose to create this behind closed doors without us and spring it on everyone in a spot bill. And sadly, the consumer and peer community has been intentionally excluded and disrespected, and the ableism of that needs to be called out. The very people who dreamed up the MHSA and who stood outside grocery stores and collected, I checked how many it was, 380,000 signatures to get this on the ballot. The people who have skin in game, the clients, have been ousted and silenced. And this amounts to basically a hostile takeover of our law. And we're watching legislators too afraid of some unstated consequence to buck the governor and vote against something they clearly do not wish to vote for. And the question is, do you have the guts to buck the governor if you believe this is not good policy? I hope that you do.
Thank you.
Thank you, Claire.
Next, we have Leandra. Your line is open.
Hi, everybody. Thank you for the opportunity to share public comment. I am Dr. Leandra Clark-Harvey, CEO of CBHA. Our founder worked alongside Daryl Steinberg and others to make the act a reality. So we're heavily invested. We represent mental health and substance use disorder provider agencies across the state. We are hopeful to continue dialogue with the governor's administration and the legislature as these final weeks tick away. And we feel the pressure and appreciate the amendments that have been taken thus far. And we still have a few questions. I've not been able to fully digest the amendments that have come out, and I'm thankful to the OAC for the overview that you're giving the community today. It's very helpful. But in some of the areas that are still outstanding that our members would like to see addressed would be some type of accountability for managed care plans, that be put into the proposal. Also, that there be clarification around the division of PEI, and also consideration around combining PEI to allow counties to really utilize the funding in that so-called bucket as needed based on the needs of the Medi-Cal recipients in their various counties. And then also that flexibility be restored as much as possible to FSPs. We know that these full service partnership models have been incredibly successful, and there's a lot of excitement around how to build those out. But we ask also that we stay true to the tenets of FSP, which is whatever it takes. So some of the accountability that's been built in and the amendments, I think for providers was very restrictive. So we're going to continue to have conversations about that. Hopefully we'll see some more change there. Thank you for the time.
Thank you, Leandra.
Next, we have Danny. Your line is open. Oh, sorry, go ahead, Danny.
Hello, my name is Danny Therical with the California Youth Empowerment Network, and we vehemently oppose SB 326. Homelessness is primarily an affordable housing issue and not a mental health issue. The state oversees multiple programs aimed at reducing homelessness and has spent billions of dollars trying to solve a housing crisis, and we are still no closer to our intended outcomes. We have not exhausted all other means of addressing these issues. We have not discussed rent control, holding municipalities accountable for building the required housing, or focusing on the high cost of living in California. The administration should be having those conversations and looking at those possible solutions, but only then should the discussion of using MHSA funds be had. But the SB 326 bypasses this process of engagement, discussion, and planning, and rushes a proposal that may not reduce the number of unhoused and may actually reduce mental health services. The MHSA should not be reallocated. The funds should continue to serve our most vulnerable populations with a serious mental illness so that they may receive the supports and services they need, including the housing interventions, which are already allowed and available in full service partnerships. We ask this commission to vote against supporting SB 326. Thank you.
Thank you, Danny.
Next, we have Sharon. Your line is open.
Good afternoon, commissioners. I wasn't going to raise my hand until I heard Commissioner Carnevale say to shout loudly. So I'm going to do that. My name is Sharon Jennings. I'm a resident of the County of Sacramento. I'm clean and sober 35 years. a consumer of mental health services for more than 50 years, and I served as a legislative employee in the Senate for 31 years. This process has not been exactly transparent. I know that when the county introduces a proposal, it is posted for public review for a period of 30 days. I think that the efforts of the administration are noble, but I think the approach is incorrect. I'm thinking that given that homelessness is a nationwide disaster, and furthermore that 30% of this population is in California, why should we not ask FEMA for assistance? Please, commissioners, use your collective voice to shout loudly and say no on SB 326. Thank you.
Thank you, Sharon.
Next, we have the number ending in 718. I believe Steve Leone, your line's open. Steve, if you want to go ahead. There we go.
Hear me now?
Yes, we can.
Okay, I think you're unmuting me while I'm trying to unmute me, and the net result is I get muted again. Anyway, I'm Steve Leone, consumer and advocate of many years. And as some may know, and most probably will not, I was involved very heavily 25 years ago in the startup of first AB 34 and then the MHSA. I was at the table with Rusty Felix and others as the whole thing was being crafted. So it's from that perspective that I speak. I'm going to not speak about, buckets and money and all of that has been spoken to well. However, I'm speaking about core of what makes the MHSA the MHSA. Back 20 years ago, 25 years ago and more, a lot of people were concerned to take more people into the communities instead of in IMDs, etc. And the counties generally didn't have enough money or they didn't understand how to support those people. So the MHSA was meant to provide a program and money, just that, bring people into the community and to reduce the overall use of involuntary care, which often alienated people actually, and this was much more effective. Now we're being told a lot of that is being modified, and this is under the radar screen of most of what people are talking about. And that is that the full service partnerships are going to be, Toby said earlier on, they're not manualized and not standardized. Well, they're going to be standardized. And they're going to be standardized at levels of care. You step down. That's what they do in San Francisco, which is where Gavin Newsom is from. And those step downs are based on acuity. We used to talk about severe and persistent mental illness. Now it's more like, well, if you have less acute, then we'll step you down to lesser services when maybe the greater services were actually helping keeping you safe. There's that piece. And then there's another piece that I'm actually hope I'm very wrong about, but they talk about stepping down to less intensive care within the FSPs. Now, in a section in 5806, which was traditionally represented the clinical model of the village model that started the FSPs, talk about providing
Steve,
services.
if you could please wrap up.
The least restrictive environment, and then it says these shall not apply to Medi-Cal-based programs. My concern here, and please ask for an answer to this, my concern is, sounds like the most intensive level of the full service partnerships might actually be voluntary. I hope I'm wrong, but the language as it's written leaves that open. So please look into it.
Thank you, Steve.
Next we have Holly. Your line is open.
Hi, thank you. Good afternoon. Holly Tan on behalf of the California Pan-Ethnic Health Network in an opposed unless amended position on SB 326. CPEN is in the process of reviewing the amendments that went into print over the past few days, and while we appreciate the changes to consistently apply the use of CDEPs, particularly for early intervention services and the expansion to include a commissioner who is knowledgeable on CDEPs, we remain concerned about the lack of specific and actionable focus on racial disparities in SB 326. The lack of specific and explicit benchmarks pertaining to racial equity will risk leaving thousands of communities of color behind and further exacerbate the behavioral health crisis for underserved communities. CPEM would like to uplift the following additional concerns. 1, substance use disorder treatment and housing interventions are now optional for counties, which contradicts the vision to encompass behavioral health more holistically under the MHSA. This is discriminatory and will invite implicit bias when determining who receives services or not. And 2, the proposal fails to leverage resources across the continuum of care and will stretch limited resources to a breaking point. Health plans have an obligation to provide behavioral health services, and SB 326 fails to account for their mandated responsibilities and instead places continued burden on our local healthcare providers. I thank you for your time and for holding the space, and I hope that you take these concerns into consideration. Thank you.
Thank you, Holly.
Next, we have Lauren. Your line's open.
Can you hear me? I'm Lauren Ritaliata, a family member of a loved one who has lived on the streets and who has a serious mental illness and a meth addiction. I implore you to listen to the wisdom of modernizing the MHSA. How do you make a good bill better? You modernize it. And that's what we need to do. I wasn't here in California yet. I got back here to my home state and I met Rose King, one of the initial authors of MHSA, and I met legions of mothers and fathers who marched the streets asking that MHSA, when it was initiative, be passed. We have a lot of skin in this game, and our loved ones are the ones that are not getting the care that they need right now. And I implore you, with the modernization of MHSA, that this will happen. We have legislators that have worked very hard on this. This did not happen real quickly. They have been working very hard. They have been listening to all of us when we take the time to contact their office and give them our point of view. Thank you very much, and I appreciate your giving us the time to speak.
Thank you, Lauren.
Now we have our last public comment. We have Laurel. Your line's open.
Hello, I'm Laurel Ben Hamida, a founding member of Muslim American Society Social Services Foundation in Sacramento and REMCO. And there are so many things that have been said. I have to say that I agree with those who are unhappy with this bill, who feel that and who know that they were not at the table during the drafting of the bill, and that it's being legislated at such a speed that unwise decisions are being made. That despite some of the additions which Stacey Hiramoto mentioned and others, but nevertheless, there are large problems. For example, we are short 1 million units of housing in California. To solve that, you would have to cut all the mental health services and give them to housing. Look at what Karen Bass is trying to do in Los Angeles, how Cal Matters had a very good article about that. They can get people off the street, but they don't have the services. They don't have the staff to solve the problem. So people are in houses, but not getting services. We don't have the bilingual clinicians to provide clinical services. So there's so many problems. I see us as politicians move on in their careers being left with a large mess to solve. And I can imagine being told by the average person, well, if you want to get mental health services in California, you better get evicted first. Then you might have a chance if you're on the street. So these are just some of the problems that I think the rest of us who are staying where we are will have to clean up. Thank you.
Thank you, Laurel. I want to thank everyone who shared their public comment and for the discussions that my fellow commissioners engaged in prior.
Chair, I apologize, but it looks like Hector Ramirez had a comment. His hand has been up for a while. I'm not sure if we just missed it.
I'm sorry, Mariani.
Yes, hold on 1 second. Go ahead, your line's open.
Thank you, Hector Ramirez. Yeah, somebody kept putting my hand down. And I think that really goes to probably the point that I want to bring up now. I think the modernization needs to happen. Here in California, 1 out of 3 Latino youth considering suicide, despite the fact that we're not only the majority and billions of dollars have been spent. You know, our population, particularly our Latino community, which represent the largest ethnic population in California, is just so grossly underserved by the MHSA in our counties because our populations are not prioritized, they're not served correctly. The peer certification movement in LA County completely, in a very racist and discriminatory, disenfranchised our Latino stakeholders and our promotoras. So I think one of the things that I would hope in this modernization act is that there's a particular focus, not only on the consumers like myself that try to attend these meetings and kind of always have to deal with hostility from the commission, but similarly that our communities, as we come here looking for help because we can't get them from our mental health commissioners and our board of supervisors, that we're able to not only be able to share these concerns, but hopefully not only have you listen, because I hear we listen, but actually have some actual action, or even tell us that this is not the place. This commission, in the way that it is, became a wrong door for our communities, became the wrong place for our communities to try to seek help. And that is one of the reasons why this should happen. I'm not necessarily in agreement with the way that it's been happening, but it has been happening. Why? Because our youth, my gente, my population, the people that feed you, the people that pick food, that clean your houses, those are my community that are so underserved and so grossly inappropriately served by this commission. And so those are one of the things that I hope that you would continue to elevate, particularly since you mentioned that you're from our communities, to really advocate for us as you move forward. That's what modernization should really have been done. And that's something that should have been done from the beginning of the Mental Health Services Act.
Thank you, Hector. Hey, now, thank you everybody again for your public comment. So, and again, I want to thank my fellow commissioners for the conversations before that. At this time, I would like to entertain a motion on SB 326. As a reminder, when we take a position on legislation, the staff communicates our position to the governor and legislature in the form of a letter. So given the significance of this legislation and the tight time frame for taking a position, I would ask that the motion include direction for the staff to prepare that letter to reflect our position and to be signed off by the chair before it is submitted. And I would recommend that we take a support position with the following concerns, a lot of what we've heard here today. So community engagement. The language of SB 326 was not developed through a community engagement process. That needs to be remedied with a robust commitment to engagement with peers and families on implementation, particularly for any accountability strategy. School mental health. As a follow-up to SB 326, the state needs to establish or at least clarify leadership and accountability for sustaining attention on school mental health after the CYBHI said the Child and Youth Behavioral Health Initiative sunsets. Disparities. All behavioral health reform efforts need to focus on addressing disparities and achieving equity for the communities most impacted by unmet mental health needs, including Native communities, Black, Latino, LGBTQIA, veterans, and others, and prevention. The emphasis in the behavioral health reform proposal is on care delivery and early intervention, and that is necessary. We must also ensure that we don't lose sight of the value and opportunity for prevention. More work needs to be done to lead with prevention in everything we do in the behavioral health space. That would be my proposal. happy to hear modifications and entertain a motion. Commissioners, please.
Madam Chair, I move that we support the bill and direct staff to write a letter precisely as you have just articulated.
Thank you, Commissioner Carnevale. I believe I saw a hand raised. Commissioner Chambers, please.
You mentioned modifications. I'm wondering if we can put language in there relative to mandating peer support services or something to ensure that peer support services is preserved, which is the outpatient.
It's not modifications, it's just highlighting concerns, because I think we've missed so I believe it's just highlighting our concerns with it. So we can add that, Commissioner.
I would
Chambers, for sure.
support adding that.
Thank you, Commissioner Carnevale. So that way, Commissioner Chambers, just because he supported the initial, so would that suffice?
Yeah, I was just responding to you when you made a note. Was there any modifications to your statement?
Thank you. Thank you, Commissioner Carnevale. So adding that, which Commissioner Chambers stated, including peers.
I think we need a second to Commissioner Carnevale's
Yes.
motion, right? So I'll second.
Thank you, Vice Chair Alvarez. So we have a motion and a second to approve the motion. Are there any additional questions or comments from commissioners? Commissioner Rolette, please.
I've articulated some concerns regarding the existing effective service array and how that might get, again, I understand that it's just articulating a concern, how that might get woven into a letter to the governor and the administration would be important to me.
Thank you. So we would add that language in, Toby. Add that letter into, or add those concerns that were mentioned by Commissioner Rolette as we shape that letter. Thank you, Toby. Commissioner Bontrager, please.
Just a quick question about timing. This bill is obviously not static. It's dynamic. It's being amended with a flurry of amendments over today and the next few days. I'm a little uneasy about supporting a bill that is still in progress and not knowing what that outcome might be in the next few days. Are we voting based upon what we know today? What can you give a little insight into that?
Toby, can you just share with us the next day's process?
Yeah, thank you. So typically when the commission takes a position on the bill, it's the bill that's in print. And we recognize that legislation often evolves even after the commission takes a position. We monitor that. And then, there's a judgment call, some assessment if modifications were inconsistent with the language that the position that the commission took. And we work closely with the chair to sort of assess whether or not the commission's position needs to change. That's sort of standard practice in these scenarios where legislation is dynamic.
Thank you. That's helpful. I just wanted to ensure that if there's some abhorrent amendment that comes about, that we're not on the wrong side of history.
Thank you, Commissioner Bontrager. Any other questions, comments from commissioners? So Toby, so based on the motion and adding both what Commissioner Chambers and Commissioners Rolette said, if we can just make sure that we are all in agreement there. So if you can recap that for us.
So that's right. So the motion is that you would take a position, in this instance, the motion is a support position, and direct us to draft a letter that is reflective of this conversation. And so the chair laid out my notes: community engagement, school mental health, disparities, prevention. Commissioner Chambers wants us to reference a mandate for peer support services to implementation. And Commissioner Rolette asked us to reference paying particular attention to ensure that the existing service array is not adversely impacted, right, or inappropriately impacted through this shift. So with that motion, we will draft a letter. We will present it to the chair for review and approval, and we'd be happy to share that with others if you want to make sure. Usually what we do is we check in to make sure the wording for Commissioner Willette's concern, the wording for Commissioner Chambers' concern is reflective of what they meant. The commission's rules of procedure allow the chair to sign off on final communication for these, and so we typically follow that procedure.
Thank you, Toby. So at this time, then, I would ask, we have that motion, the second. I see no other hands raised for questions or comments. So I would ask Jeff if you would please take the roll.
I would, Madam Chair. I would also like the record to reflect that since I took roll at the beginning of the meeting, Commissioners Bunch, Commissioner and Assembly Member Carrillo, and Commissioner Carnevale have joined the meeting. Now the roll. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Bunch, could you repeat, please?
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Opposed.
Commissioner Chen.
Aye.
Commissioner Cortese. Commissioner Danovich. Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Abstain.
Commissioner Rolette.
Abstain.
Commissioner Tamplin.
Oppose.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
Madam Chair, the motion passes.
Thank you, Jeff. Thank you, everyone, for joining us today to continue work on discussions around mental health. We would especially like to thank members of the public. Our next commission meeting will take place on September 28th in Los Angeles. We look forward to meeting you then. Today's meeting is adjourned.